conference, and by no means the least, is from Dublin in Ireland, from a dear colleague and a friend, Professor Ed McKone. Professor McKone is a consultant respiratory physician in the National Referral Centre for Cystic Fibrosis, Adult Cystic Fibrosis in St. Vincent's University Hospital in Dublin. Professor McKone has participated immensely and published extensively, particularly all the trials relating to modulators and extensive experience in registries. But today he's going to talk to us and finish this, kind of put the icing on the cake about aligning research with CF clinical practice. Ed?
So thank you, Basil, and I'm really delighted to be asked to speak here today. Can you see my slides?
Yes, we can.
Great.
Thank you.
Okay. So just by way of background, the picture here is, this is a building in St. Vincent's University Hospital. We have a very large cystic fibrosis unit. We've about 400 adults attending our unit, and you can see here we've 2 floors of this building on the top picture here that are dedicated for CF care, a 20-bedded inpatient unit as well as a 10-bedded daycare unit. And what I want to talk to you about really is about aligning research with CF clinical practice. And really what I wanted to go into detail over is trying to generate a research culture within your CF clinical care program in order to both improve how you deliver care, but also to monitor any improvements that you try to introduce and make sure that you're delivering the best possible practice. So what I'm going to talk a little bit about is integrating research and CF clinical practice through optimizing CF care, through things like introducing the model of CF care and also CF care standards. As you know, and sure, and those who look after adults will realize that actually quite soon after looking after adults, you realize that we're beyond the evidence base. And when we're looking at patients and the evidence that we've used, or the evidence that we've used to deliver care so far is running out, and we need new ideas, how do we approach that? And also how do we keep up to date with all the vast amounts of literature that come out in the area of cystic fibrosis? And then I'd like to talk a little bit about, in your day-to-day care of people with CF, how can we use research to monitor our practices? And I'm going to talk a little bit about registries and also about benchmarking, where you can learn to compare the quality of the care that you're delivering with other centers to make sure that you're delivering the best care. So many of you will have seen this slide here. This slide has been used in many talks that have been given in cystic fibrosis, looking at the changes in survival that we've seen in cystic fibrosis over the decades. And as you can see here, there's been very remarkable improvements in survival over the years, just before even modulators have come along. And this is attributed to a lot of different factors, including enzymes, better antibiotics, airway clearance, and also this sort of multidisciplinary team. And I suppose it just highlights the incredible importance that research has had into clinical care over the years, and how our understanding of the pathophysiology of CF and how we deliver CF clinical care has led to big improvements. Now, this picture drops around 2010, but I have extended it now to where we are right now, which is we're seeing much greater gains in median survival. And in fact, median survival publications recently from the US and Canada are estimating survivals in the 50s. In Europe, we've been doing the same with our registries, and we estimate survival again up into the 50s now for people with cystic fibrosis. And a lot of this is before the advent of modulators, or certainly before modulators have had an impact on survival. So this suggests again that the existing treatments, and as well as the clinical care we deliver, has led to significant improvements. So research and clinical practice, if we go back to the 1960s, there were 2 pivotal papers published in the Journal of Pediatrics from Leroy Matthews and also from Karl Dorsuk. And this was a good example where clinical research led to substantial changes in clinical practice that also led to improvements in outcomes for people with CF. And this was the first 2 papers that decided that they would cohort their CF patients into a single unit and manage them with expertise from nutrition, from CF clinicians, And what they found was where the median survival had been about 6 years in most centers around the United States at that time, their median survival was dramatically better than that, up to 15 years, which of course is a low survival compared to where we are right now. But it was much, much higher than the standards around that time, indicating that this form of clinical research and the development of cystic fibrosis centers had a really big impact on outcomes. And a very simple example of where clinical research had a very direct impact on clinical care. Now where are we at this point? This is from Scott Bell's Lancet commission in cystic fibrosis that was published last year. And really what this slide shows is the models of care that have been developed around the world. And really what the models of care have done is that they are now trying to harmonize how we look after people with cystic fibrosis and the best way to deliver healthcare services for these patients. It outlines the best practice care and services that are required for cystic fibrosis. But as you can see here, in green we have the comprehensive models of care, which many countries have. But you can see that there's a large number of countries that have not developed a model of care. It's either limited or partial, and in many cases it's undeveloped entirely. There's also what we do recognize as well through registries is that there's a lot of countries where we would have thought that cystic fibrosis is relatively rare, but because of the very large populations in these countries, there probably are a lot of cystic fibrosis patients that are undiagnosed. So developing models of care is a really important way to use existing research and standards that have been set by CF experts and clinicians to set up your cystic fibrosis care delivery. In addition to models of care, we also have standards of care, and the standards of care were published in 2018 by the ECFS. And this really is a very comprehensive document that updates all clinicians who look after cystic fibrosis on the best way to look after CF patients. This is a ECFS document that was published in the JCF back in 2018, but also different countries have developed it themselves, including the US, the UK, and we have our own one in Ireland. So this is something that I think that as you're beginning to develop your cystic fibrosis care and you want to use research to ensure that you're delivering the best care, developing a standards of care program for your unit or for your country is really critically important. And these are really comprehensive evidence-based assessments of the best way to care for patients. But as we know, a lot of the time, as soon as you're reading this, it's already becoming out of date. Since these have been published, there's been extensive additional research, so this outdates quite rapidly. So it's very important that you're maintaining your skill set in assessing the CF research. So when evidence-based medicine runs out in the care of cystic fibrosis patient, and this happens a lot, particularly in adult medicine, and when we're aware of the randomized controlled trials that have showed benefits like drugs like DNase and hypertonic saline, azithromycin, inhaled drugs like tobramycin, astrinam, Quinzair, and drugs like levofloxacin, and to a lesser extent colamycin. These are fantastic treatments, and we have a lot of patients on them, but a lot of the time, despite being on those treatments, they're still sick, they're still exacerbating. When they come into hospital and we're using conventional antibiotics, they're no longer working. You know, what do we do when we run out of ideas that are based on the evidence base, based on these models of care? So we have to seek evidence. And how do we seek evidence? Well, we need to look at the different approaches, and this is the pyramid for evidence-based medicine. And as you can see, the peak of it is the systematic reviews, and then below that is the randomized controlled trials. There's a lot of debate, though, about the other roles of cohort studies, case control studies, cases, and particularly the lowest level on this is the expert opinion, which is extraordinary when we think about it, because a lot of the time when you look after CF patients and you don't have any evidence, it's expert opinion is what you require. And so this is something that I have to say I'm not entirely in agreement that this should be such lowly ranked, particularly when cohort studies and case control studies, there's a lot of them out there that really haven't been done that well. But the important thing is that when you're looking at research and you're determining how you're going to adopt it in your practice, is it any good? Does it change practice? And then even if it does change practice in some cases, should it change practice? So keeping up to date in cystic fibrosis, so looking at PubMed, there's been 55,000 papers published in the area of cystic fibrosis. And in fact, there's been 40,000 of those since the year 2000. So you can see how incredibly difficult it is to maintain your literature, to keep up to date with all the literature. Even if we limit it to the top two peers of that pyramid, there's 1,600 randomized controlled trial and systematic reviews available on PubMed. And also what you can note as well, there's about 3,000 publications per year in the area of cystic fibrosis. So how do you maintain your skill set? How do you approach keeping up with this research and also applying it into your clinic? So this is where it gets a little bit more nuanced. And I suppose there isn't any clear guidance in this area, in that there's much more than one way of doing this. So really what I'm going to talk about is what we do in our centres and how we work together in Ireland to try and ensure we're delivering the best possible practice using research. And this will be both at a national level and also at a local level. I think this might be something that also would be interesting to discuss maybe more openly in the questions and answers at the end. So obviously from a national, international perspective, we look at our standards of care and we make sure that we're following those guidelines as best possible. But as I said before, a lot of the time, the patients we're looking after are already on the standards, but they're still running into difficulty. Of course, there's review articles, there's peer-to-peer, which I think is an extremely important mechanism of sharing information and sharing experiences in CF. And it is interesting to remember that peer-to-peer, which is really like consulting with your colleagues who are looking after people with CF, and I think that's hugely important in how we manage CF. That has a very low ranking in terms of the evidence-based pyramid that I showed before. But I think in cystic fibrosis, the idea of having MDTs, and we've even been talking about sharing difficult cases with other colleagues in the country to come up with a management plan, or even just to discuss management plans. I think that is a really important resource that people in the cystic fibrosis community should be developing. Of course, medical meetings. Now, medical meetings have gone virtual now, but we all know that medical meetings, despite beyond what we learn when we attend sessions there, a lot of it's about the meeting of our colleagues in the evenings and in the breaks to discuss cases and learn about how we're managing cases. So these things, unfortunately, have been affected by COVID. Hopefully, we'll get back to that next year, because these are very important resources. And of course, there's a lot of online resources. And I suppose two that I would think are worth mentioning. The first is the ECFS educational portal, and they will obviously have courses there. The second one, though, is online resources like PubMed. And what I use PubMed a lot, like most do, but you can set up searches there, which will search the sort of high impact journals. So like the New England Journal of Medicine, JAMA, Lancet, those sort of journals, and JCF, and they will send you each week an update on literature that's been published. You can then scroll through it, identify what you think is relevant to your practice, and then download the abstract and papers as needed. So I think they're very important ways of maintaining your skill set and your continuing medical education in CF. From a local perspective, and I suppose this applies to not just to cystic fibrosis, just to medicine in general, is obviously journal articles, and of course ensuring that you're getting access to the high impact journals. Now, it is interesting. I always think, though, that even papers published in journals like the New England Journal of Medicine, which you would expect would influence practice, often don't. And I think a very good example of that is the ibuprofen study in cystic fibrosis, which showed benefits of ibuprofen long-term in children with CF, but it hasn't really been translated into practice. And I think it just shows that there's still a lot of biases that people have, and despite clear evidence base that may support a treatment, I think a lot of people have their own biases about whether they're going to introduce it or not. So I think translating from research into clinical practice is actually much more nuanced. We all have our own biases. Some papers we like, some treatments we like, and even when we start treating people with them, there are some that we will like more than others, and that can become a bit more of an art than maybe science-based in terms of how we deliver them. I mentioned case discussions. That's extremely important as well. Case discussions are something that we would promote every week in our training program, where we present cases to our colleagues and we discuss case management, and also it's a very good experience for our trainees. We've also introduced a thing called clinical conundrums, and this is something that we do once a month, where our trainees, our fellows and SPRs, will each have to pick a question on some aspect of the management of CF or management of respiratory disease. So say, for example, the evidence behind tranexamic acid in the case of somebody with a massive hemoptysis. And what they will need to do is they will define the question, and they need to answer with just a small number of papers, 3 or 4 papers. It's not a full review like a state-of-the-art lecture, but it just allows them just to start thinking about using literature to answer the clinical questions that come up on the wards that aren't necessarily covered in standard of care review documents or reviews like, say, Up to Date, those sort of things. So I think that's very good, and it does teach them the skill set to critically analyze literature, which I think is very useful. And then, of course, clinical research. And I think that I'm going to talk a little bit about research in a few minutes, but clinical research is really important. And when I was training in the US, and something that we've introduced now is clinical research works in progress, where each month people who have research ideas, before they even develop their ideas and start doing it, will present it to the group, and then we can discuss the pros and cons of the research to ensure that it's well designed, and how to prepare a clinical research proposal, and then of course going through ethics and other various things that are required. So that's a very important part of maintaining the education of our trainees, and particularly our CF unit. Now, I want to talk a bit more about the MDT as well, though. This is our MDT in St. Vincent's University Hospital. And it's a large number. We have a lot of physios, we have a lot of dietitians, we have microbiologists, we have nurses, and we have doctors. So it's a big team. We have a psychologist and a social worker as well. And we have weekly CF inpatient MDTs where we go through all the inpatients in the hospital, outlining what treatment they're getting, how they're responding, and whether we need to adjust their therapies. We also have annual reviews, which are obviously the requirement for CF patients to have at least one annual review. And that's a good opportunity to go through their treatments and make sure that the evidence-based, that they're receiving their evidence-based treatments. We have a monthly journal club, and this rotates through the team. So the physios might present 1 month, and then we'll have the clinicians, the doctors may do it another month. We have the dietitians as well. And this sort of, again, promotes a culture of research amongst the teams to present work that other people have done, but also to suggest ideas of research we might do ourselves. Meeting and networking I've mentioned before, but this is also critical for the team, that they get to go to meetings like the European meeting and the North American meeting, and our local and national meetings where they can work with their colleagues, they can share ideas and experiences with colleagues. In addition, courses in cystic fibrosis. And interestingly, although we do miss not being able to go in person to meet people at these meetings, some of these meetings are more accessible now due to COVID because we don't have to travel, so that we can go online and we can see lectures being delivered. And that allows us to attend and keep up to date through courses that we perhaps wouldn't be able to attend prior to COVID due to limitations in annual leave and also the cost. But again, the important thing, and I think what the outcome of all of this is really to try and promote a research culture within the cystic fibrosis unit. So the question, of course, is why do research? And I think a lot of our trainees would view research as being more of a burden than necessarily something that they really want to do. In many respects, they love the clinical work, and they're in their comfort zone doing it, and research just seems to be a distraction from that. And I would have been guilty of this myself when I was a trainee, that I just wanted to do clinical care, and research wasn't a priority for me. But it really is such an important skill set to acquire. And I mean, what research teaches us really, it's the ability to find, interpret, and use data. And that's so important when the evidence base is when you don't, the guidelines aren't telling you what to do, you need to do something in addition. And medicine evolves very, very fast. So we need to know that we need to be able to keep up with the changes. It teaches critical thinking. I mean, I think that the assumption that if it's in the New England Journal of Medicine or it's in the Lancet, that this is, you know, the best quality and we need to change practice is not always the case. And I think it does allow people critical thinking to interpret literature for themselves. It also gives a good understanding of the methodology of research, because often, as you know, the flaws are in the methodology, and they also need to look at the biases and limitations that exist in medical literature. Although a lot of the time they are explicitly stated in the papers, there's a lot of biases and limitations that aren't, and it's important to know what sort of biases and limitations can affect literature and be comfortable with that. And of course, I suppose the other big part of research is that it's fun, it's collegial, it's part of the contribution. I mean, the CF community is an extremely tight-knit community relative to other diseases, and we work very well together. But one of the aspects of CF that really involves everybody is doing research. And I think it's really an important part of the community. And I think most would agree that pure 100% CF clinical care, it's a very tough job. And I think that if you have a research interest on the side as well, it really does complement your clinical care. So then the question, of course, is if you are thinking about developing a research program, what is the best research for your institution? And there are a number of options. And one of the options, for example, basic science, what we found in Ireland is that we have a lot of trainees who go abroad and they may work in labs, or even during their training in Ireland, they work in labs and they do a lot of fantastic bench work, but they never do it again. And as soon as they leave the laboratory and start working, that's the science that they've learned, the skill set that they learned is not used. So my feeling is that I'm much more in favor of other types of research that are a little bit more well, easier to adapt into a clinical program where you may not have dedicated funding for research. And in particular, clinical research in epidemiology and using registries. And as Basil said when he was introducing me, I have an interest in registries, which I'll talk about in a few minutes. Another area that we're looking at developing here, and I think this is another critical area, is a clinical educator or teaching role. That learning the skill set of how to teach properly. And I think that's going to be an area where we're working on in Ireland now to try and develop programs for trainees who are becoming pulmonologists and ultimately CF doctors, that as part of their training, instead of doing bench work, they will actually learn they will go down a clinician educator track and they will become educators at the end of it. And then of course, benchmarking, audit and quality improvement. This is really critical as well, because these are really important ways that you can use research to improve your work and ensure you're doing a good job. So how do you know you're doing a good job? And this is where I'm going to talk about registries, because I'm a really firm believer in the value of registries. And this is just an example of 8 papers. I'm not going to go through them all, but in essence, registries have had a big impact on how we manage cystic fibrosis. The high-fat diet, Toronto versus Boston registry study back in 89 has changed our nutrition. CFTR2 is great for understanding how the diagnosis of CF is made, and that's based on registries. Pregnancy outcomes in CF, all of these different areas, and benchmarking different centers. Registries have given us this, and ultimately leading to now estimates of survival for the US and Canada, and something we're working on at a European level. So what do registries do though beyond epidemiology? And if you look back over the last 15 to 20 years, there was a first surge of registry-based studies that were predominantly epidemiology. But in the last couple of years, what we're beginning to see is a much more nuanced application of registries. And in particular, looking at how we improve CF care at a center level. So we can look at how good centers are, we can identify areas of weakness that the centers may have, and then identify whether interventions are improving service. We can identify patients for clinical trials, which is really important because there are so many clinical trials going on in cystic fibrosis, and it is difficult to identify the right patients for those studies. And of course, with the new therapies, particularly CFTR modulators, which are highly expensive and highly effective treatments, we want to be able to monitor the effectiveness of these. And this is both important for patients to know that these drugs are working in the real world beyond the clinical trial setting, but also if your government are paying for these drugs, they want evidence to show that they're getting value for these new drugs. And then I'm going to talk a little bit about benchmarking CF care, because this is something that we've been looking at with the European registry, about a simple tools to monitor how good your CF care is and compare it to other centers. So in terms of registry and benchmarking, what to collect, and this is, I mean, this is the routine medical information that we collect on cystic fibrosis patients. So demographics, age at diagnosis and sweat test data, CFTR genotype, measures of growth and lung function, microbiology, the complications of CF, and then the different treatments that people are on, and then ultimately the outcomes, which would be transplantation or mortality. We want them though to be easy to measure, and we want to make sure the data is of good quality. And one of the things that we've been doing as part of a global harmonization group is agreeing the definitions for different data that's collected. For example, what determines whether you've got chronic pseudomonas, because there's a number of different definitions for this. But what you really want to ensure is that you don't overwhelm your ability, your registry, with so much data that the really important data that you need, the core data, is of low quality. And what we've developed as part of the harmonization group is a minimal data set that we think every registry should collect. And it's actually quite a short list. So it's something that a registry could be developed with a relatively low budget and collect just some core information that would be essential to measuring a lot of the outcomes we would look at in CF. It has to be clinically important and ideally predicted or linked to mortality. And we also need to compare it to a known standard. And these are what we would call agreed benchmarking standards. So the commonly used metrics that we would use to compare the delivery of care between one center and another would be the median age of the patients attending, the proportion of patients over 18 years old. Now, this may not apply to every country. In some country, there aren't that many over 18, but you can pick a cutoff. But it is the proportion of patients that reach adulthood in cystic fibrosis is a good metric. And you can certainly see that how much that is changing over the past 10 to 20 years, where that proportion is increasing. The median lung function at different age groups, both in pediatrics and adult. The Z-score for BMI in children. In adults, we do prefer to use the absolute measure of BMI, but again, just picking it at arbitrary ages, but that allows comparison across. So that mean BMI for adults a little older. And then the number of deaths in the current year as a proportion of the average number of patients. And that's a very crude measure. I mean, the calculated median survival is more sophisticated than that, but it's just a simple measure. And then median age of death, and then number of transplanted patients. So these are just simple data that wouldn't be that difficult to collect and allow us to compare centers. And then who should we compare ourselves with? So when we collect these data and you have it on your center, who do you look at? So what you want to do is we want to take the data, usually at the end of the year when we're happy that we've got all the data over the course of the year and the annual summary has been created. We will usually limit it to the severe cystic fibrosis genotypes, because if there's a difference in genotypes between one country and another, and we see that in Europe a lot, it's very difficult. You're comparing apples with oranges. So we try and limit it to the same types of genotype that have the same influence on disease severity. Exclusive post-transplant. And we also require that some benchmark training is advised, and ECFS runs a course on benchmark training. And then who do you compare yourself to? And what we've developed is a tool where you can compare yourself to other countries. So you can look at other countries that are maybe similar in how they deliver your healthcare. You can look at all the countries in Europe if you want to. And the other thing that we've spoken about is comparing center to center in countries. Now, that is obviously a bit of a challenge, because we don't want to develop a ranking system of centers, because there's a whole load of reasons that could lead to differences in outcome between centers that aren't related to the delivery of care. For example, if you're a transplant center, you're going to get the sicker patients, so your lung function may be lower, and that we don't want that to be misinterpreted as differences in the quality of care. So we would only consider doing center-to-center comparisons if all centers agree, and often that will be done in quite a fashion where the data isn't shared with any other centers. And then you can just see here an example of one of the workflows that we have on the CF benchmarking module, where you have a number of metrics that you can look at here. Say we've got median BMI. You select a number of countries here, that you're comparing yourself to. You take your age group, this is going to be limited to children. You take the year, and then you might take some age and gender filters. You can look at male, female, or both. And then you get your graph here, and this shows over time what your BMIs have been doing in your unit. And as you can see here, BMIs here are trending up. And this is a very, very simple way to measure whether an intervention, for example, the change to fat diet, or maybe even getting a dietitian in and seeing the impact that they've had since they started working. These are very useful ways that you can monitor the response to interventions. So I'm going to conclude, and I'm happy to take questions on these topics. I know that there's a lot that's been raised here, and a lot of it's been glossed over. So I'm happy to take questions to expand on it in the Q&A. But I think the important thing is that research is an integral part of delivering the best CF care. CF programs should develop a culture of research in their CF programs through their MDT and regular educational activity. And monitoring how research changes and improves care is essential. And I think registries are the proven tool to do this. So thank you.
Thanks very much, Ed. A fantastic talk and tour de force on how to use research in different surroundings, different environments. Very good question. The first question here, ESFS benchmarking module, is this open to everybody?
So I think if you want to contact the European Cystic Fibrosis Patient Registry, Jackie, who runs it, this is being developed at the moment within Europe, but I know that they're happy to collaborate. And actually, one of the things that I have to say about CF community is the willingness to share the things we've developed, and in particular, the ECFS Patient Registry. I've spoken about this before, actually, in the Gulf. I think this is a tool that could be developed in many countries. And I think that if you wanted to contact the ECFS patient registry directly, they'd be happy to initiate discussions about that, because I think we are keen for this to be rolled out outside of Europe.
Very
That's
good.
great. Thank you, Edward. Really, I enjoyed the talk, and it's very well designed. It's touchy. When I saw that map where our area really in the area of very low in the rank of publication as well as CF care. So my question here is one, I think one, which is a question from the audience as well. How can we shift from institutional efforts to a national efforts in terms of research, which is one of the tools of improving CF care? What is your advice?
So I suppose if I think about what we've done in Ireland, because I suppose, again, one of the things that I find is that if we look back 10 years ago, it was a much more, I suppose, patchy, or actually maybe 15 years, it was more patchy in terms of the delivery. What we've done is that the CF clinicians need to come together. They need to form a group, a working group, and they need to start thinking about how they're going to roll out these different research areas. So you need to prioritize the research areas you think would work. And that's why I mentioned the different aspects of research, like epidemiology, clinical research. These are areas of research that actually can be developed quite easily. They're low cost. You know, basic science is very expensive. It's hard to do that, but these are actually low cost. So, you know, getting statistical advice, getting in advice on how to design clinical research, forming groups like that, and then deciding what you want to do, then engaging with groups like the ECFS, because I have to say that the ECFS, we have a lot of experience working with different groups, and are always willing to open and give advice to other centers that are developing themselves. And we would look at trying to work on setting up, or at least we would share the structures that we have that work well, and you can then look at it and see how can you adapt that in your own country. Now, some of it will work, some of it won't. But I think that the most important thing is getting buy-in from people, getting people together. I think that developing a registry is a very simple way to start, because it becomes a tool that can be used for a lot of research. And again, as I say, low cost, but actually because there's a lot of patients in there, can be quite high impact. You know, and I think that particularly in areas where there hasn't been a lot of research done before, there's a real interest in the CF community about how things are going, how things are working there. So if you put together a registry, which can happen quite quickly, and the ECFS can be very helpful in how to do that, then you suddenly have a resource that can be used to promote research.
Very well. Saying that is leading to the second question. How possible is to plug in from our region, to plug in your educational activities, such as meetings or resources, or in periodically manner?
Well, see, I mean, I think this is perhaps one of the only things that has come out of COVID that is beneficial, is that the ability to access meetings now actually has become a lot easier than it ever was before. I mean, it used to be in the past you'd have to fly to a country and attend it, and that became very difficult. I think that we will hopefully go back to person-to-person meetings for the reason I outlined, but a lot of meetings are still going to be held with the ability to join in on Zoom. And you'll see that there's a lot of meetings that are ongoing that where there isn't really a cost, or there may be a small registration cost, and you can then get access to them for your hospital. One of the things that we've done, for example, during the ECFS when it was online, was that we had our MDT room, which had a projector up and was showing it live from the ECFS. And the team members could go in and out, and they could join it. They could also ask questions using the chat options. So I think I think the ability to attend virtual meetings now is much more accessible. So I think that would be definitely something that would be you should be promoting.
Very good. A question here, maybe it's a general one. What are some essential KPIs that would help improve CF care?
Yeah, so that's a really good question. And I think that you've got to keep them simple. And that's why when you look at our benchmarking tools, what are the questions that are very simple questions? Now, I think things to start with, I think that one of the simplest ones would be, how often is the patient attending? So, we expect patients to attend every 3 months. So what proportion of patients are attending for the meeting, the 4 meetings a year that we would recommend? Because we often find that that's quite low, and that would be something to try and look at improving. The second one would be the proportion that get annual reviews done. I mean, these are simple things. Like every patient should have an annual review in CF. we obviously, each year we try and look and see how many have attended and got the full annual review done. So these are very simple metrics that you can use, but it means that you're engaging with the team, that and you're also making sure that you're seeing the patients and delivering what we would consider to be the kind of core care package, which would be annual reviews and regular assessments. Other things like how many sputum samples per annum have been collected, because obviously we're screening for Pseudomonas and these sort of bacteria. And these are, and then, you know, I mean, clearly things like a lung function, where your lung function metrics are, and then seeing is that improving, you know, year on year. But I think they would be some very simple ones. I mean, and then from a country level, a very simple metric is to take an age, you know, 16 or 18, and say, what proportion of your patients are over that age? Because if you think about it, that really reflects both pediatric care and adult care. And you can see that you would want to see that moving. And you know, in Ireland, we crossed the 50% probably about 10 years ago and are moving in the right direction. And as you know, Basil, I mean, you know, one of the big things that's changed probably in the last 20 years since I started working in CF is our transition clinics now, where, I mean, it's remarkable how well the CF patients are when they're transitioning now. And in many, you know, most cases, you know, how little Pseudomonas compared to 10 or 15 years ago. So there's a good example of simple metrics that you can do to monitor your care.
I suppose you've answered the question, and that was, what are the low-hanging fruits in a limited resource center with limited number of patients that we can do? But you know, you've obviously touched on a few things. Have you got any more to add?
No, I think, I mean, again, I would keep it simple. One of the problems I find is that if you try and be too detailed about it, what happens then is that it stops happening. It needs to be very simple. And this is one of the things about a registry, is that there's an immediate, when you sit down with a group and you're saying we want to put a registry together, there's often a lot of discussion about all the information everybody wants to get in there. And there may be somebody with an interest in hepatology wants to get a liver function test in, and there's somebody else with an interest in you know, osteoporosis, wants to get all this information, but you really do need to have a simple core data set, because I think what happens is that it's the whole quantity quality debate, that if you've got too much quantity, you lose quality. And what you really need is a core data set. And I mean, you know, I remember talking to Anil Mehta about this. He said the registry should really only have 10 things. They should have age, FEV1, BMI, and then, you know, and probably a couple of things, just, you know, gender obviously as well, but and then microbiology. That would be a very simple data set. But if you have that and you monitor that, I think that you would be 80% of improvements in care would be picked up with all of that. You don't really need a lot of the other stuff.
Edward, talking about registry, one of the obstacles in the region here in our area, that most of the patients, cystic fibrosis patients, they are under follow-up with different healthcare providers. So one of the obstacles that how can you link them in one registry? What is your advice?
Well, I mean, that is a real challenge. I mean, I think that the evidence base, even going back to those papers back in 1964, is that you really do want to have centralized care for cystic fibrosis. It can be difficult to do, and there's obviously resistance from different centers. There may be logistical issues because of traveling. And actually, just linking in with Andre's talk before me, I mean, that is a good example where you could have a shared care model where you would have a core cystic fibrosis center with the expertise that's acquired, and the data is being shared from these smaller hospitals into that center. And I think that if it's not feasible for patients to all attend one center, I think that you probably do need to have a national cystic fibrosis referral unit that is that contacts, or where there is a contact between that center and these smaller hospitals that have a small handfuls of CF. And because of that, the data can be collected, even if it's only annual data, and then you can develop a registry. Because most of the registries in Europe, and some of those countries in Europe, are very under-resourced. I mean, in smaller Eastern European countries with very little in the way of resources, they have a model like that, but they are able to collect the data. You know, this is, you know, if it's online, it's easy to put the data in, and we only need one measure a year. We put in annual review. It's not encounter based. It's just once a year that they get the charts of their patients, put all the information in that was collected over the course of that year. And that can be done actually quite easily. And then you suddenly have a registry. So again, it's buy-in, and one of the other challenges is that people are reluctant to share data if they're worried that they might be compared with their colleagues. So it's really important that there is there has to be some element of trust, but if that is difficult, there has to be an element of anonymity. So that may be that there is a trusted third party where all the data is shared, it's pooled under, but it's anonymized. Centers aren't included. So you have the data, but nobody's feeling that they're going to be, the finger's going to be pointed at them if they feel their outcomes are lower, because that's important.
That's great.
I think that's the key. You touched on the key thing here, because, you know, we all like to think that we're the best doctors, and we are. We're trying to do the best for our patients. And obviously, developing a ranking system is not going to be helpful, particularly in a multi-pronged healthcare system, you know, different regulatory authorities. So I think that's key.
In the US, when they did when they first introduced their registry, there was a lot of pressure on them to develop a ranking system. And in fact, there's a very famous New Yorker article called Under the Bell Curve by Atul Gawande about the pressure on the CF centers to publish the data, comparing all the different centers. So eventually they had to. And then they introduced their benchmarking program, and they went out to the top centers and they went out to the bottom centers. And it really wasn't clinical care necessarily. They couldn't really find the differences. There were much more nuances. Now, a lot of it was leadership. I think that if you've got a good leader in your unit, that does tend to, and that culture research I was mentioning, that definitely does improve outcomes. But it wasn't as obvious as you would think. And a lot of the time, there's a lot of other factors, socioeconomic factors, expectations, cultural factors, environmental factors that lead to differences in outcomes that are not related to individual care. And I think that's really important to be clear about that from the start, so that if you identify, if somebody is reluctant to share data because they think their outcomes are poor, that a lot of the time it's nothing to do with the delivery of care. It's a lot to do with the surroundings, which are much more difficult to change.
Thank you very much, Ed, for a very informative talk and a lot of food for thought here. Something which we were, when we're designing this program, we're hoping to end up with, so that we think about how we can improve care to people with cystic fibrosis globally, even in low resource economies. I mean, of course, we've touched on many issues during this meeting about inequity in care and how can we improve, but I think getting the basics right, and I think I'll consider this one of the basics to try and kind of ascertain. Thanks again, and thank you for giving your Saturday morning. We appreciate it.